Hello and welcome to another episode of the Melbourne Athlete Development Podcast. Today, we're very fortunate to have with us Dr. John Srbely. John, thank you very much for being with us today.
My pleasure. Thank you for having me.
So, to begin with, could you introduce who you are and what you do, just to give some context for the conversation we'll have?
Sure. As I said, my journey started back in 1992. I graduated as a chiropractor from the Canadian Memorial Chiropractic College, and I continued practicing both chiropractic and acupuncture. And my journey kind of took me sort of a meandering route really, through the area or the field of myofascial pain or chronic musculoskeletal pain where I practiced. And I started noticing a lot of very interesting results and effects of both acupuncture and chiropractic that I really couldn't resolve using standard Western biomedical jargon. So that kind of inspired me in 2003 to go back and pursue a graduate research degree at the University of Guelph, where I currently am full-time tenured professor now, just to pursue some of these questions. And, I kind of, again, was inspired by some of the early work that I did in research, and just kind of continued along this path where I'm now, as I said, full-time tenured there, studying chronic myofascial pain, focusing on mechanisms of chronic myofascial pain, as well as some treatment modalities and so on, which I'm sure we'll get into later in the podcast. So that, I guess, in a nutshell, is my route.
So, I was going to say, to begin with, John, this term myofascial pain seems to be thrown around a lot these days, and actually seems to be very relevant to a lot of clinical presentations, because I think of, say, back pain, the majority of back pain is non-specific in nature. So can you describe what myofascial pain is and its relationship to a lot of non-specific pain presentations that people present with?
Yeah, and that's a great question. I think that's the million-dollar question in the field right now. Sort of as a preamble to that question, I think what any of us who are studying any of the work in this field will see a very stark sort of evolution of terminology in the field. So terms like myofascial pain, myositis, etc. These were sort of terms that they're more descriptive. And I think what's happening now is we're kind of understanding or studying mechanisms, I think, to a much greater degree in terms of understanding what this phenomenon of myofascial pain is. And I think that this comment applies to nonspecific low back pain as well, which simply means that we can't identify primary pathology. But again, we'll talk about that, I'm sure, later on in this podcast, because this is work that we're currently doing. So myofascial pain generally involves an experience of discomfort in the myofascial tissues. And I think one of the things that we need to really understand and appreciate is the difference between musculoskeletal pain and true myofascial pain. And so one being more acute, nociceptive type pain, which is the musculoskeletal pain, which we'll talk about. And that involves typically a breach to the myotendinous unit. So an injury, a local injury to the muscle. And this is sort of the integrated hypothesis of Simon's. Whereas I think the work that we're doing, I've done during my PhD, and I think there's some other work, but I think I've kind of sort of driven this concept forward more, is this concept of neurogenic inflammation and neurogenically mediated pain, which can happen in the absence of local injury. And I think we'll talk more about that. So myofascial pain is the pain in the myotendinous region. However, we have to distinguish it, I believe, from true musculoskeletal pain, which is more nociceptive. So I'll start with that, and maybe we'll get into some detail.
Well, I was going to say, because you've associated musculoskeletal pain with nociception, do you not make that same connection with myofascial pain? Do you classify that as a different type of pain descriptor?
Yeah, that's an excellent question. And this is exactly what drove me back to school in 2003, was that I was noticing, and again, the Simon's integrated hypothesis suggests that the origin of myofascial pain necessarily involves a local injury, a breach to the myotendinous unit, a tear, a structural injury, if you will. And that creates a type of pain called nociceptive pain. So if you can describe that pain, it would be a very localized. So if I were to apply pressure to a local injury in a muscle, you would get a very sharp, well-demarcated pain that would evoke a withdrawal reflex. Now, those of us who have practiced, and at the time, again, I was practicing a lot of manual therapy manipulation, I wasn't noticing this with my patients. Those of us who practice, digital or manual pressure on a trigger point, what do you notice? You notice, at least I noticed that the patient wanted more pressure. So I would apply sustained pressure to a trigger point, and you'd get into a conversation with the patient, of course, during the course of your treatment. And then I would notice is they would start pushing harder against my thumbs. And, initially you don't register that. And then eventually it's like, well, this doesn't make sense. Is this an injury, or why are they pressing harder? And certainly they weren't withdrawing from my pressure initially, right?
That's a
So I
very
think this is,
interesting observation, John, because I think that what it seems to demonstrate, which is obviously a very intrinsic thing, that people are aware that that digital pressure actually is in some way helpful, even though they may not understand the mechanism behind why it might be helpful. And it is an observation that I've had as well, that as soon as you apply pressure to that area, the patient will actually say, oh yeah, that's the right spot, you need to keep pushing there. Even though there is a level of discomfort that is perceived at that site, which I find it very interesting. I don't know whether you've studied that, or why people actually intrinsically understand that that is useful to apply pressure to that. That in itself, I think, is an interesting phenomenon.
So you noticed that as well?
Oh, totally. As soon as they will verbalize straight away, oh, that's the spot, you need to push hard there. And you think, that's not comfortable. You know yourself that if someone pushes into it, or even you do some self sort of treatment, or you get the ball out or some foam rolling or something like that, straight away you notice like, well, that's uncomfortable. But there is this weird intrinsic perception that that actually is helpful. And I don't know why we know to some level that we actually, that may be beneficial.
This is the core. I mean, this is really the core question. And again, the one thing that you'll notice as well, it doesn't evoke a withdrawal reflex. It can evoke a withdrawal response where the patient can eventually pull away. That's not a withdrawal reflex neurophysiologically. So I'm actually writing a review right now, which hopefully will be out in the next month or two. And I talk a lot about this, so I bring these issues up. But that is the core question, right? Is that is non-nociceptive pain. So as you say, intuitively, when you talk about pain, the definition of pain is an emotional experience. If I come at you with a needle, you're going to withdraw actually even before I apply the needle to your skin, because you're perceiving that as a noxious stimulus. Not the case with trigger point therapy. And so there clearly is a difference in the quality of the pain. And that's why, I started questioning the local injury model, because it just didn't make sense. It wasn't nociceptive pain.
That raises a few questions for me, John. One of the first ones is, when we think about pain, I know a lot of the classifications that are taught here describe it as nociceptive, neuropathic, or nociplastic. Now, I've also been quite critical of that oversimplification, because if you look at some of the definitions, you realize that a lot of particularly non-specific pain doesn't fit into nociception because of often odd referral patterns if there is some type of trigger point causing myofascial referral pain. In the myofascial pain you describe, how would you classify that pain then? Would it fit into one of those three categories, or do you think that there's actually, we need more different categories to describe some of these more non-specific types of presentations?
Well, you guys are asking some very good questions. Yeah, so this is a great conversation. I mean, you're getting to the crux of you're getting to the crux of it only took me 25 years to figure that out. You guys are figuring it out.
Well, that's why
we're taking us longer.
I was about to say we're happy to have people like you to help speed up the process of us understanding what to do.
But yeah, so you've highlighted the three types. Now, the nociplastic term is an interesting one. I see it as more of a descriptive term. Basically, it's just it talks about it basically refers to plasticity or maladaptation of the nociceptive pathway, which really speaks to sensitization. So, my colleagues and I, we talk about this quite often. And, again, what we need less of is jargon in the field, and we need more mechanism, I believe, mechanism-based terminology. So to me, that pain is allodynic pain. It's allodynia.
Mm.
So this pain, so you guys are familiar with the term allodynia?
Yes.
The audience would be?
Well, they
where
can
it's
look it up if they're not sure.
Sure, okay. But the idea is a discomfort or hypersensitivity, or in severe cases, pain to a non-noxious stimulus, which is very often a mechanical stimulus. So this is exactly what trigger point manual therapy is. So it's an allodynic type pain. It's non-noxious. It will not evoke a withdrawal reflex. And this is exactly what we see with myofascial pain. And so allodynia, if we understand the neurophysiology of allodynia is only expressed in regions of secondary hyperalgesia. Okay, and that's subsequent to central sensitization and neurogenic inflammatory mechanisms. And so this really ties in very nicely. So my hypothesis that I established in 2010 of the neurogenic hypothesis of myofascial pain talks about this, where I suggest that myofascial pain is in fact allodynic pain expressed within regions of secondary hyperalgesia subsequent to CSEN, central sensitization, due to a primary pathology residing somewhere else outside of the muscle, but neurologically connected, right? So allodynic pain is, I think, the term that most appropriately, at least mechanism-based term, that most appropriately describes the sensation that we're getting from the myofascial tissue, true myofascial pain.
Can you explain a little bit more about the neurogenic inflammation, the neurogenic hypothesis? Because you've obviously briefly touched on looking at the neuroanatomical relationship between different tissue structures, but can you elaborate further and describe some of the mechanisms?
Yeah, so neurogenic inflammation is a term that I remember when I graduated from Cairo school. I mean, I heard about the term, but I didn't really appreciate the term very much. And I practiced for, 12 years before going back and really not appreciating, the significant role that it plays in the clinical manifestation of a lot of conditions. So neurogenic inflammation. So what happens is if I introduce a pathology, a primary pathology, let's say in any organ, any tissue, doesn't matter. As long as it's persistent, what will happen is you will get a persistent nociceptive bombardment of that dorsal horn, whatever segment innervates it. And so we're going to get sensitization. And what if that's allowed to persist, we get substance P, glutamate building up in the dorsal horn. What happens is we get a mechanism called primary afferent depolarization, which then activates any of the convergent nociceptive pathways and non-nociceptive pathways. So all of the fibers that converge onto that dorsal horn then become activated. And what we see is primary afferent depolarization. Then what we see is a dorsal root reflex, which is basically an antidromic response within typically the unmyelinated fiber that converges onto that. So let's say, for example, we have a pathology in the spinal disc, for example. So osteoarthritis, which is something that I'm advancing, this concept that I'm advancing with OA. So you have a primary pathology of persistent nociceptive bombardment, let's say of the C5-6 segment. All right. That segment becomes sensitized. Primary afferent depolarization kicks in, which effectively depolarizes the afferent terminal in the dorsal horn. We set up a dorsal root reflex, which is basically an antidromic response in the unmyelinated fiber, and that dumps substance P and CGRP into the peripheral tissues. So again, here we see that neurosegmental connection. Mm. And so, so if that substance P is dumped into a muscle, my hypothesis suggests that is what triggers the myofascial pain. We get inflammation locally, which then triggers a whole cascade of events in the muscle. And that's been shown in animal models, visceral responses as well. So Ustinova group has done a couple of really nice studies where they introduced a primary pathology in the colon using an animal model, and they saw an inflammatory response in the bladder within 3 days, as well as hypersensitivity, i.e., allodynia, in the bladder tissue as well. So it's the same mechanism. The only difference being that in myofascial pain, I believe that it's happening in muscle.
So when we talk about this starts to really illustrate that there is a relationship between certain pathology, and like in this example, you could say joint pathology, and changes within the peripheral tissue. And I think the thing that's really worth highlighting here, and goes back to your original point, is a lot of the way that we think about pain is about structural pathology, a soft tissue strain, a soft tissue sprain. But what you're actually describing here is environmental changes that influence the local tissue environment, and potentially maybe even the mechanics of how the tissue slides, that can be a source of pain itself. And I actually see that as potentially one of the issues at the moment with a lot of clinicians or researchers not being open to myofascial pain, because you can't see clear structural pathology on some type of radiological investigation.
Same with any kind of, quote, chronic pain, right? The clinical sign of that is that you can't identify a primary pathology. So there's a maladaptive response in the nervous system. So I think what we need to understand is that, clinical manifestation. So you have a pathology in tissue, but then the clinical manifestation is the sum of the pathology plus the maladaptive response in the nervous system, right? And so, we can take, let's say, a chronic disc, for example. Somebody comes in with an 8 out of 10, I can dry needle them, and they walk out of my office with a 2 out of 10. Well, I haven't changed the disc at all, but I've altered the nervous system excitability. So you can see how that clinical presentation has been immediately resolved. Same thing with the Ustinova work. I mean, that inflammation in the bladder, to a pathologist looking at that under a microscope, they would say, well, there's a pathology in this bladder. But there isn't. It's neurogenically mediated inflammation. So it's an interesting concept, right? Is that a real pathology? Is it a secondary pathology? Certainly, if you allow it to persist, it will lead to fibrosis and pathological or structural changes, which I'm showing now with an animal model that we're using, which we can potentially talk about. Yeah.
What are you seeing with that? Can you describe what's happening in that research?
So what I did was I basically, a couple of landmark studies in this area where this was during the pandemic, so we couldn't really do any human research. So we were able to do some animal studies, which was kind of a bonus. But what we did was, one of my theories was then, what primary pathology in the body, if this neurogenic hypothesis is valid, then what primary pathology would potentially drive myofascial pain in humans? And so what I noticed, or what we know very well, is that age is a risk factor for both OA and myofascial pain. But nobody has really looked at the causal relationship between OA and MPS. Does one cause the other, and so on? So what we did was we did a couple of studies actually where we looked at that relationship. So we took a geriatric population of rats, and very often in my talks I confess I didn't know that rats became geriatric. but
they suffer from the aging process like the rest of us, I guess.
They do, yeah, they do, and quite remarkably, actually, I found out because we have at Guelph we have the top vet college in the country, University of Guelph. So there's a lot of good veterinarians and vet surgeons who I work with, and they say that. Even if it's a quadruped, the rat model of OA, spine OA, it's actually quite valid for humans, believe it or not, even despite the fact that they're quadrupeds. So we used the rat model, and we saw a spontaneous OA group. So in the geriatric population, we saw OA in the lumbar spine, spontaneous, and we saw increases in substance P, neurogenic inflammation, in the segmentally linked quadriceps. Okay, so that's an observational study. It's cross-sectional. I couldn't make any conclusions on causality. So what we followed that up with was with a young cohort of rats. We did surgical intervention where we actually induced OA in the lumbar spine. We opened them up. We compressed the facet joints, closed them up. they go on, and and then we sacrificed them after 21 days, and we saw increased neuroinflammation in the segmentally linked rectus femoris, but not the biceps brachii. So we use the biceps brachii as a segmental control. So again, showing that OA is definitely a potential primary driver of neurogenic inflammation, and could very well be a cause for myofascial pain in the aging population. And so this follow-up study, we're looking at a more chronic, so same study, but we're sacrificing them at 84 days. So we're letting them kind of get into a more chronic state, and we're seeing increased collagen. So we've got this inflammation now in the muscle, and now there's increased fibrosis. So it's really cool. We're building a trigger point.
Is this relationship of the neurogenic hypothesis bidirectional? Because I'm thinking about people that we see who develop myofascial pain due to overload because they're an athlete and they're creating a lot of mechanical tension and local inflammation that leads to peripheral tissue changes, or very often to underuse, or not to mention even actually following a, say, soft tissue strain there where there is changes to the myofascial tissue that actually then can potentially influence inflammation to the spine at that segment.
You mean so you set up a focus in the muscle that now becomes a primary pathology? It's very possible. The one thing about the muscle though is that it's highly vascularized. So muscle tissue typically heals very well. So unless there's a chronic aggravating factor, there has to be. So the key thing to this is persistence. So OA to me was the obvious one. But very often, as you know, so it is very possible. Yeah. So you create these.
It may depend on the. I was going to say it may depend on the actual pathology to the peripheral tissue, because like I'm thinking maybe say following an infection that may lead to severe fibrosis of the tissue.
The thing that it makes me think of, Jack, is people who don't actually rehabilitate well because for whatever reason, and then their tissue. You see the tissue properties not actually recover to the same level you would see if someone who's actually gone through quite a significant rehabilitation period. And then you tend to notice that they're describing, myofascial type pain, even though if you think about the tissue healing time, it would typically have, as you mentioned, John, you'd expect it to have already healed because of the vascular sort of supply to that area.
Yeah, no, exactly. And that's a very good point. But there has to be, so in the muscle, there has to be some sort of mechanical aggravating factor that's producing a primary pathology. Now, the trick here is, and again, these are conversations I have with colleagues. We call ourselves the myofascianados, by the way. I'm not sure if you. So it's a very exclusive club.
I'm about to say a very select group.
Very select. It's hard to get into. But the thing about it is that, to your point, is that yes, it could become a primary pathology. However, the caveat here, and again, this is something I discuss in my review, is that if it does become a primary pathology, the quality of the pain will change, or should change, right? It should become a nociceptive pain. You see, so this is the dichotomy here, right? That we're all wrestling with. We've all, and there's probably 100 years of clinical experience on these calls. That we have our Friday afternoon calls with Lynn Gerber, Siddhartha, Jay Shaw, myself, and we're still asking these fundamental questions, right? So yes, that's a possible mechanism that you describe. However, that theories are only as good as the clinical observations that they explain. So in that case, that doesn't explain the fact that this myofascial pain is soothing, that it's non-noxious. So we'll have to. Maybe we're missing an injury mechanism, that may be able to produce non-noxious pain. The other thing is that I was thinking of just quickly is that this persistent pain also, what's one of the first signs of an occult tumor? If you guys have picked up it. Trigger point. Okay. What's that?
Yeah, okay. No. Go
on.
On.
So trigger point very often are pick up subclinical or occult tumors or like I said, underlying or preclinical type conditions that produce persistent pain. So that's something that you can use as a clinical sign as well. So if a trigger point's not going away, for example, even despite treating it, that's a red flag that there's an underlying, pathology, that's pumping nociceptive input into the system.
Yes. Yeah. Okay. The other thing it makes me think of, John, talking about neurogenic, the neurogenic hypothesis, is there's been a lot of research looking at the general asymptomatic population and the high prevalence of certain types of spinal pathology. When you look at the high prevalence of certain types of disc pathology, facet joint degeneration, even potentially bony changes within the vertebrae. And I know there's a lot of research highlighting that these are often very common in asymptomatic populations. It makes me think about the neurogenic hypothesis about, is something like a disc bulge something that we shouldn't ignore? Because is that something that's indicating that there is some changes in potentially the mechanics of the joint that's leading to some level of irritation, inflammation, and may actually feed into the neurogenic inflammation?
Excellent question. Yeah. So this is something that, we teach, is that, a disc bulge is actually, very often, what's the first sign of a disc bulge? We're all of us are sitting right now, and very often a tight muscle will be the first sign, right? Very early stages of a discopathy. So you get bulging, you get the recurrent meningeal nerve being activated from the disc bulge, and you get this reflex hypertonicity in the muscle to stabilize that area. That's the earliest sign. We basically write that off very often. Oh, it's just a tight muscle, so on. But to the astute clinician, they'll understand that. So one of the first questions I would ask a patient who I suspect would have a discopathy would be, how do you feel when you're sitting? Do you feel a little tension? Certainly pain. If you feel pain, then obviously, but tension in the muscle. And if they say, well, yeah, then what about in a car? A long car ride where you're getting the axial compression, so you're getting increased compressive forces. So that's a dead giveaway, right? So to your point, subclinical nociception can actually lead to low grade neurogenic inflammation and sort of a very light grade. Like, this is a spectral disorder, right? And so an interesting thing you might be interested in is probably about 10 years ago, I collected some data. We used topical capsaicin cream, Zostrix, chili pepper, to evoke a very transient short-term sensitization. So we target specific segments, let's say C5-6, by applying it to the C5-6 dermatome, and then we create this transient sensitization effect, and then we study whatever physiologic effects. Well, one of the effects that we studied was motor unit recruitment. So we use the first dorsal interosseous muscle, and so that's C8T1 innervation. We sensitized the C8T1 dermatome, and what we found was remarkable. I'm not even sure I wonder if I have pictures of this, but you'd be amazed. So the reason I say this, here it is. Yeah, if I can share my screen. Can I share my screen?
Yeah, down the bottom you should have a button that says share. Does that come up on your
screen? Yeah. Window, here we go. All right, can you see that?
Yep, it's coming up now.
Yeah,
we've got that. Perfect.
Yeah, so this is really cool. I mean, I think you guys would appreciate this. Is that so? What we did here was we just wanted to see what the effect of central sensitization would be on motor unit excitability. So here are the EMG tracings. So this is pre-sensitization. And can you see my cursor?
No, I don't believe so.
Oh, you can okay. So the top,
we can see pre-sensitization.
yeah.
Graph
So the top
above,
window
yes.
is pre-sensitization, and the bottom window post, obviously. So that's after we apply the cap cream to the C8T1.
Just to explain to people, where are you actually applying the cream to?
So it was to the C8T1 dermatome, so the upper back area.
Yes.
So specifically targeting that because of the FDI being innervated by the myotome being innervated by C8T1.
Yep.
So what you'll find cool here is the line tracing. That's the force tracing. Now that's increasing. It's going down, but it's increasing force. We just had the poles reversed.
Okay,
so that's increasing force in both cases. And the bottom tracing, of course, is the EMG. These are the single motor units kicking in. So you can see on the top that you've got the standard Henman size principle. You've got recruitment of the smaller unit, and then as force increases, we've got the larger units kicking in higher rate coding and so on. That's normal. In the bottom, you see a very different effect, right? You see a very hyperexcitable motor unit pool. And I'm not sure that you can see the scales on the y-axis, but that
really.
bottom peak on the bottom window, the bottom peak is about halfway down when you look at the top one. So you're looking at half the peak force of the top tracing, and you can see the number of motor units that have already been recruited. So the excitability of that motor unit pool has gone
Inhibited,
up.
yeah.
You're seeing much, and that's crazy because we're using very at the bottom. You see in red, mild transient sensitization model. Well, the analogy to this would be subclinical, right? And you can see the immediate effect. This is within 15 minutes.
In John, the thing I think about straight away with this is some of the issues and limitations about how we talk about motor control, and not actually using the term sensory motor control, because what this is highlighting here is that when you get altered afferent feedback due to, say, sensitization of tissue, that alters the ability to recruit motor units, and you're seeing a change in the motor output. And it's something that, obviously a lot of this research has been done by a lot of researchers here in Australia of highlighting this idea of maybe using certain types of internal cueing to quote unquote recruit or activate muscles, but actually realizing that maybe some of the limitations has to do with peripheral regulators inhibiting the ability to contract alpha motor neurons.
Oh, clearly. Well, you can see it in that data right there. And again, the emphasis on that is the mild sensitization model. So you can, my argument here is that real pathology would be orders of magnitude greater and persistent. So you can just imagine the maladaptation that goes on in that motor unit pool. This happened in 15 minutes with topical cap. Right. So we have so and again, to your point, imagine what that will do to fatigue, to motor unit recruitment, et cetera, over time. Subclinically, a lower disc is innervating the knee joint and knee muscles, for example. So biomechanically, is there dysfunction now? Motor unit recruitment, is there sort of recruitment of muscles, the coordination of muscle recruitment, is that altered in the knee? Does that impact OA? Does that accelerate OA? We don't know. But it's significant.
You mentioned this before, and that is central sensitization typically is a response to the bombardment of nociceptive input to the central nervous system. And I'd like to hear your thoughts more on this, because I feel like a large message that's being portrayed in central sensitization is the importance for things like explaining pain and understanding psychosocial elements associated with central sensitization. And that's not to suggest that those things are actually not relevant or important. But what at least what I'm getting from what you're saying from your research is, if there is peripheral bombardment because of changes to peripheral tissue, if we don't address that may be actually a key variable or factor associated with resolution or improvement of central sensitization.
100%. Yeah, exactly. So as a clinician, the sort of the Monday morning messages, continue treating trigger points. I mean, you can treat them with needles. I treated them with ultrasound, manual therapies and so on. But you need to identify the primary pathology in your workup of the patient. So you need to identify, that which is driving this. What's producing where's the primary pathology? In other words, so if you're pressing on a trigger point, if you're evaluating your patient, you're finding, soothing pain. That you are in, that's allodynic pain. That you're in a region of secondary hyperalgesia. The pathology is not there. It's somewhere else. And so you need to find that primary pathology. And to me, the red flag was, so the trigger point itself is a clinical sign. So again, if it doesn't resolve with treatment, then that's a red flag that you've maybe missed a primary pathology in occult. It could be an occult tumor. It could be in rare cases. But they're so common that I was looking for a common pathology, and OA seems to be that pathology. It creates the perfect storm.
Is there a similar relationship between OA or degenerative changes in peripheral joints as well to tissue as outside of the spine?
That's a great question. You guys are asking really good questions. So there's what's interesting is that pain arising from axial tissues is very different from pain arising from the peripheral tissue. Now, have you read Howie Vernon's paper?
I'm
Howie
not
Vernon,
sure. I'm not
you know
real
who
good with
Howie?
authors. No, I don't know that name off the top of my head. No.
Yeah, he's an icon in the chiropractic profession. He wrote a great paper. I'll forward it to you guys on the
Please do.
difference between central and peripheral pain. And his argument is, again, I mean, we're wired differently peripherally and centrally. That
Mm.
there's, one of which is just a higher density of afferent information coming in from the axial tissues, because the spine itself, phylogenetically, is the oldest structure, and it's a proprioceptive structure as well. And so, there's a lot of afferent information coming in. So a pathology in the spine will create a much greater bombardment. And he argues, as evidence of that, is that, spinal pain refers into the periphery, but peripheral pain typically does not refer centrally.
Mm.
So it's a really good paper, actually, to address your question. So yeah, a chronic knee OA can create sensitization for sure. Again, as long as it's persistent. But spinal pain seems to create a much, more intense and lasting sensitization state.
When you start talking about all the research that you've just mentioned, it then starts to give us appreciation for thinking about changes within the peripheral tissue. How can we go about assessing this? Are there any particular methods that you recommend, or can we actually feel these changes with our hands, or is it something that we get information from the patient to give us indications of what may be connected to their problem?
Yeah, and so if you read that paper on back pain that we published there with Sikdar
Mm.
and Stecco and the group and Gerber and Shaw, this is something that we on non-specific low back pain. This is something that we talk about. How can we evaluate this? And so my argument, and again, it's in my review that should be coming out shortly. My argument is the single most important clinical sign to me is the quality of the pain.
Yes.
Obviously, the palpation, feeling these locations is part of eliciting that. So, finding the tender spot, interrogating it, challenging it, but you have to ask the patient, about the quality of the pain. And the real bifurcation point in your clinical assessment is this noxious or is it not? And so, as you mentioned earlier, the patient will tell you right away. If not, their behavior will be a dead giveaway, right? They won't shy away from it. So intuitively, they're drawn towards it.
Mm.
So that is non-noxious pain. If that's the case, you're in a region of secondary hyperalgesia. It's that black and white. Allodynia does not occur in a region of primary hyperalgesia where the pathology is. So I think that's the real key pearl, I think, for your clinical assessment, is this noxious or non-noxious pain.
Do you expect to feel changes within the tissue quality itself because I'm thinking about some of and you mentioned that fibrosis could be a potential a long-term maladaptation, and it also makes me think about some of the work from the Stecco group about this concept of densifications. We get changes within the extracellular matrix of the loose connective tissue. Are these all things that you think clinicians with building up their palpatory skills can feel and identify?
Yes, a great point. And so the caveat I have to that is, yes, there's going to be peripheral changes. We're seeing that in the animal model that we're working with, right? We take it from 21 to 84 days, which is acute to chronic, and we're already seeing increased collagen. Well, that's going to feel different to the clinician. Obviously, fibrotic tissue is going to feel harder. And so what you need to appreciate and be aware of is that the myofascial condition, the myofascial pain condition, is a spectral disorder, right? So if you follow the mechanism here, in the early stages, it's going to be more inflammatory. So it's going to feel different. When it becomes more chronic, it's going to feel more fibrotic, right? So I don't think there's sort of one set
Yes.
of, so you have to be aware of that. And that's going to come out in the clinical history. You can ask the patient how long have they had the pain and so on, and you can kind of gauge from that. But you will feel, I think, a different sort of sensation depending on where they are in that spectral disorder. And we've actually, Siddhartha does a lot of ultrasound imaging. He's published in that area. And I remember when we first started talking about his studies, he was noticing that, the clinically tender locations were both hypo and hyperechoic.
Mm-hmm.
And we were having this discussion. And so it came, I thought of, this kind of spectral disorder, right? So neuroinflammation initially will be more fluid dominant, which will be hypoechoic. And then if we allow it to progress, as I have in the animal model, we're going to become more fibrotic, which is hyper. So it could just be various stages of the pathophysiology, and so that's kind of the thinking that we have now that explains what he's been seeing on ultrasound.
Mm-hmm.
Mm-hmm.
You may be able to answer this question for me, John, because this is something that I've been wrestling with recently, and I've spoken to John here about it as well. And that is the pain that we experience with nerve root compression and inflammation from, say, like a disc pathology as an example. Because something that seems to be evident from my clinical experience and talking to other clinicians is the type of pain descriptors that people present with can vary a lot. And often when we think about nerve root compression, we think of radicular pain, which is that sharp shooting, lancinating pain down the leg, which may or may not always happen. And I know Carla Stecco, you may have read her paper, The Dermatome and Fasciatome, and she's suggesting that that may be related to the innervation of the deep fascia that typically can present some of those more sharp, intermittent types of pain. But the thing that I realize with these type of presentations is you don't necessarily always get that type of pain. You may also experience other types of pain like a dull ache or changes to the dermatome when you think about, say, heat pain, or even sometimes more those affective type pains when you think of that sickening type of pain that some people also describe. And something that I've been trying to think of, well, why do we see these different types of pain presentations with a nerve root compression? And my hypothesis is related to the fact that there are obviously different types of tissue that are innervated when we think about the deep fascia, the muscle, because we know that obviously we can get a weakness, but obviously the muscle can be a source of pain itself, the superficial fascia, and then of course the sclerotome as well, the periosteum innervated by a particular nerve root. Could that be an explanation for why we see variations in nerve root type of pain depending on what particular tissue seems to be affected innervated by that particular nerve?
Yes. Yeah. Great question. So the first thing is radiculopathy is you described the burning, the lancinating. That's neuropathic pain. So that's an injury to the nerve itself. So it could be a mechanical injury, could be a chemical injury, could be infectious or whatever. But that is, and again, this goes back to my point of quality of pain. That quality of pain is critical to your diagnosis. And helping you identify the primary pathology. So in that case, if a patient presents with neuropathic pain, we know that there's damage to the nerve, or there's direct irritation to the nerve tissue. And so in that case, again, very often we're looking at a disc herniation and so on. But definitely deep somatic pain, for example, like cutaneous pain is usually sharp. Deep somatic pain will be more of a dull ache. Fascial pain, and there's some studies where they injected hypertonic saline onto the fascia.
This is the Andreas Schilder's work.
Sorry?
And this is Andreas Schilder's work, isn't it?
Yes.
I think that's how you pronounce his name.
Yes. And so they're talking, again, very unique type of pain, very sharp type of pain as well. So again, the key though is that referred pain is non-noxious. So if I we know that the fascia, and Antonio and I, we talk about this a lot in terms of the fascia itself. The innervation of the fascia is highly innervated by these unmyelinated fibers. And so if you evoke C-sens to a segment, the fascia that's connected to that segment will undergo neurogenic inflammation or will be exposed to these neuropeptides, right, through these antidromic responses. That will not Again, nobody studied that, but I suspect that that will not create an acute, noxious, like hypertonic saline type of pain.
Okay.
So this is the thing that we're now, this is kind of the frontier of research now, is we need to understand the mechanisms of allodynia, secondary hyperalgesia, because there's no injury to the muscle there, to the fascia there, right? So this is just strictly neuropeptides that are being dumped onto the fascia. Nobody's done this yet. So that would be an interesting study. But I think in that case, you would not see, again, it's about noxious versus non-noxious. I think if you want to boil this down, noxious pain versus non-noxious, does the patient withdraw? Do they just want to withdraw from the pain? Does it evoke a withdrawal reflex? This type of thing. Is it well demarcated? Right? If it spreads, that's non-noxious. So, to your point, a lot of research still needs to be done in that area, right? But great question.
Are there any particular, is there any research that's been done, or even actually just from your experience with clinicians, working clinically, of different treatment interventions to treat the peripheral tissue and restore, say, a normal tissue environment? Like you mentioned some of them before, whether things like dry needling, probably even other different types of manual therapy techniques. You actually said you even used to do ultrasound, which I'd actually be interested to hear a bit more about, because ultrasound, particularly in our world in Australia, has certainly fallen right out of vogue. Some of the research that is often cited has to do with looking at ultrasound versus a placebo ultrasound to treat. Actually, I can't remember what the specific conditions were. Do you know what it was related to, John?
No, I think the biggest issue with it is that they were not able to describe the mechanisms well, so therefore it was pushed by the wayside. And so if you don't, as you know, if you don't have good mechanistic research, it's hard to continue to use something, because now in the world that we live in, unless you can suggest that you've got some evidence, people consider that as, not best practice.
Yeah, exactly. Well, there is. I mean, there is. Sorry, go ahead with the question.
No, I was just going to just to finish off. So I'm interested to hear about, are there even any other types of novel types of treatment interventions that are coming out that you think may be better provide solutions to some of these peripheral changes?
Yeah. So I think so the mechanisms then to treat the trigger point itself. So that phenomenon, which again we haven't really fully described yet. So we
go into that.
It's
start there.
What's that?
Yes, start there, please, by all means.
So the trigger point itself being the hyperirritable locus, the neurogenic hypothesis actually describes that as, again, with I've got a if I can share another slide here,
Of course, me too.
I can really, it's pictures worth 1,000 words, of course.
This is actually a first, I think, people sharing their screen. It's good.
Is it? Okay, here we go.
It's only taken us 100 episodes, but we've got someone who is technically savvy. It's good.
For our listeners on audio, you might have to go to the YouTube channel and have a look.
Okay, so can you see that?
Yeah, we can.
Okay, I'm just going to switch to that. So this is the neurogenic hypothesis in a nutshell. So basically, here's your primary pathology. So it could be somatic, like a degenerative joint, or visceral. Okay. You've got a persistent nociceptive input, sensitization. And now what we have is this antidromic response. So this is in this fiber here. So these are the unmyelinated fiber. And so that's innervating a muscle here. Okay, so here we have the substance P. Okay. Through interneuronal pathways, intersegmental, intraspinal pathways, we can also activate the preganglionic sympathetics here in the intermediate horn, and I've published a paper on that using capsation again and infrared thermography, as well as you've seen, the ventral horn, so we can alter the motor unit excitability. And so it's the coexistence of these three pathways now that create a myofascial trigger point region in the absence of local injury, right? And here is the spindle as well, which I've added to this to the mechanism. Partnan's 2010 paper is an excellent paper. I would highly recommend. But again, through this, these unmyelinated pathways, we can activate, because again, it's a very tight capsule and it's innervated by all four types of fibers. So you can see here that we can activate the spindle through neurogenic mechanisms, which can then activate the gamma motor neuron loop, which can then create this persistent contracture. So you can see here, preganglionic sympathetics, we can evoke these hemodynamic changes that Siddhartha has shown. The retrograde diastolic flow that he's shown on ultrasound. We have the inflammation, which creates the tenderness, and we have the local contracture directly through the ventral horn as well as through the gamma motor neuron loops. So the trigger point phenomenon itself is complex in this regard. Now, what we can do is we can treat it as well by, let's say dry needling. We can drop a needle in there. And what we're doing there is we're stimulating large myelinated fibers predominantly. And what that's doing is it's the gate control mechanism. So stimulating large myelinated fibers will block pain at that segment. So it's Melzack and Wall, 1960s. So that's really what I think is happening. We can also manipulate this segment. I've actually got a bunch of studies here. Well, here's what I did with the capsation. So this is the intermediate horn. So I applied cap here, and I did infrared thermography, and I looked at the differences. And you can see here there was significant decrease in the temperature at the contralateral homologous side versus the lower back. There's at least almost a 1 degree drop in temperature, which we did not see in the control group, the placebo group.
And the thing I find really interesting about this, John, is I think the often underappreciation for not just, say, muscular changes, but also vascular changes, and how that also then can, I guess, create a negative feedback loop to some of the peripheral or local tissue environment changes.
Yes, absolutely, and that's really, again, I think that's what we basically need to appreciate here, is that it's multidimensional. So what we can do here, as I shown here, and there's no animation here because it's a PDF. Well, again, we can inject the trigger point, wet injection. We can dry needle, and that will block pain temporarily. So again, acupuncture works in this way. And so the caveat here is that we're not curing, right? So I think sometimes acupuncture will take it one step further. They'll modulate nausea, for example, and they'll say, "Look, I've cured your nausea." Well, you've desensitized the segment. However, the primary pathology is still potentially there. So you need to address that. It could be through biomechanical treatments. It could be an infection. There's case studies where after treating an infection, the myofascial pain disappeared. Right. So there's again, the treatment will largely depend on where the primary pathology is as well.
Well, and this also then helps to explain some of the viscerosomatic presentations, which I know there's actually been quite a bit of research of looking at the pain that can be generated through the musculoskeletal system related to pathology of particular organs as well.
Yeah, and this is one of the other. So these were the observations. So, this is one of my presentations, and here you can see here that, I started questioning many of the clinical features of the trigger point suggest that the pathophysiology might not be due to local injury mechanisms. And, I've already talked about this non-nociceptive pain, but the other thing that jumps out at you is the fact that there's a growing number of comorbidities, non-musculoskeletal comorbidities that are associated with myofascial pain. And here's, again, several studies. Jay was involved, my colleague was involved here, chronic pelvic pain. And when they treated the dysmenorrhea, the myofascial pain disappeared in the pelvic region. Right. And so we actually started, this is unpublished data, but we started Jay and I and a couple of students, we started doing a literature search on the comorbidity of myofascial pain and visceral conditions. And you can see here that, again, the prevalence is quite high in a number of these. So you've got cancer, sexual dysfunction, dysmenorrhea, chronic pelvic pain, endometriosis, and you can see here these box plots where the mean prevalence here is roughly about 50%. But in some cases, i.e. in cancer, some studies are up to 100% comorbidity of myofascial pain with cancer. So you've got, and endometriosis seems to be another one where you're getting a high prevalence. So definitely this is in the absence of local injury. This cannot be explained using local injury in the muscle. This can only be explained through central mechanisms. And so that's where the neurogenic hypothesis comes in.
You'd be familiar, John, with the work of Antonio and Carlos Stecco of this concept of densification that I'd explained before. And that is, it changes to the extracellular matrix of the loose connective tissue that alters gliding within the sublayers of the fascia. Is there a relationship between a densification and a trigger point, or are these two distinctly very different things?
Excellent question. Yeah. So Antonio and I, we were in Paris when he first showed me this, and so the densification, our early discussions, he basically was showing me this, and I remember him saying, well, obviously the gliding mechanism is decreased, right, because of the densification, and so he's saying that you're irritating the nociceptives.
Yes.
Yeah, but I kind of, at that point, I kind of thought, okay, well, how are you irritating the nerve endings if you're reducing mechanical stresses, right? You're not moving as much. And so you guys are familiar with the early osteopathic work, right, of facilitated segments. Are you familiar with that? Deafferentation?
No, I'm not.
Okay, so that's an interesting concept. So the early osteopathic work, with Erwin Core, talks about this, and so deafferenting. So to your earlier point, and we talked about the importance of afferent information. So the yin and the yang, if you will, afferent information, which basically controls the sensitivity. So these large myelinated fibers maintain a certain level of excitability at the spinal level. If you remove that from, let's say, a C5-6 segment, if I deafferent it, what happens? We create a facilitated state. So that segment then becomes facilitated. This was published in the concept of reducing motion in a spinal joint. And what we find, if we fixate a joint, if we take away that range of motion artificially or through OA, what happens then is that afferent bombardment decreases because of lack of movement, and we get this disinhibition in that segment. Okay, and so this has happened, and so I suggested to Antonio that could be one of the mechanisms here. That the fascial gliding provides that afferent information, right? It's proprioceptive, right? And we know that fascia is proprioceptive. Now you remove that could create a disinhibitory mechanism at the level of the spinal cord. And that happens in all tissues. I mean, there was a recent, not recent, but there was a paper, I think, where they actually talked about this finding. I was actually here at the University of Toronto, I believe, and they were studying the beta cells in the pancreas, and it was a new. I remember reading the paper, this groundbreaking discovery where they basically deafferented the pancreas and it started spitting out insulin. And I thought, well, that sounds to me like a mistake. Somebody went in and just accidentally cut the nerve, and all of a sudden, the beta cells start to produce insulin. Well, that same idea, deafferentation. So I think that's an important concept here with respect to your question. Densification will reduce motion, reduce the afferent input, proprioceptive input, which then sets up that spinal segment or heterosegment to facilitation, sensitization, in other words. So that's a mechanism that I think that we're going to be talking more and more about.
Okay. So yeah, clearly there's a lot more work to be done in understanding the exact mechanism there. And again, I guess from that, then understanding its relationship to trigger points.
Yeah. So, but once you've established sensitization, then the trigger point follows suit.
Yeah, so well, that makes
So,
sense. Yeah, because
so yeah.
we have
So
that understanding.
yeah,
Yeah.
yeah. Hmm.
Do you have any other questions, John?
No.
John, we always like to ask our guests about anything that they're doing, typically outside of their professional work, that's of interest to you at the moment. Is there anything that you're exploring, anything that you're reading that has got your attention at the moment?
Well, exploring. I mean, I'm very busy right now at the university,
No doubt.
so there's a lot of no, very consumed with this. I think our group. I'm in with a vibrant group. Lynn Gerber, Jay Shaw, Siddhartha, Antonio,
Mm,
and we are, I think, at an inflection point. I'm in the midst of two. I think really well, one of manuscripts, one of which is that review paper, which again should come out, and I think it'll generate a lot of discussion in the
mm.
field. And another paper actually looking at secondary hyperalgesia. So yeah, I mean, right now at that point, at this point, I'm really working on. I think we're really moving the needle. I think in the field. So very excited about it. I only have. I mean, I'm pushing 60 now, so I've got to get this done before retirement age.
No,
So I'm
we
excited.
appreciate it. We appreciate it. It's really good to see the level of passion that you have for it, because everyone who works in healthcare, particularly related to pain and musculoskeletal pain, and the variations associated with it, we are all still, I think, searching very much for understanding what generates a lot of these pain presentations. So it is much appreciated that you're pushing the cart with this
Mm.
and your group.
And just to add to that, I think you always hear a lot of clinicians talk about, or people talk about the body's connected and we need to look beyond the
Mhm.
side of pain. And this actually starts to really help explain some of the mechanisms behind it. And I think that's so important to be able to evolve our understanding about how you treat the body and interventions for treating the body to understand how that influences changes to tissue and pain itself.
Yeah, and I think, and I'm getting the sense from both of you that you guys also see that there's something very profound here.
Well,
That yeah.
I think the thing that's very evident, and certainly within physiotherapy in Australia, there's certainly been a move away from manual therapy, and it's become very exercise focused. But it's interesting to see, particularly a lot of clinicians working in sport. You see them use manual therapy still a lot, and that
Mm.
says straight away says something about its potential benefit when you have the importance of having athletes be able to perform and maintain a high performance and understanding the
Mhm.
value of manual therapy just through clinical experience. And I think the big thing that's really important here is to understand some of the mechanisms behind it. And I think drawing from that, understanding how other pathology within the body may contribute to the development of myofascial pain and how that can influence sensory motor output that obviously can make someone more susceptible to injury.
Yeah, and I think, from that chart, the EMG tracings that I showed you, for an
Yes.
athlete, for example, who relies on, muscular control and coordination, you can see here how an early onset or subclinical disc might impact it, and then a manipulation or some type of manual therapy prior to performance can enhance performance. You
Mm,
just feel, I mean, we've all felt it, right? After a treatment, you feel looser, you feel lighter, you feel like you're
mm,
more coordinated. So, I think we're beginning to explain these things using sort of the standard Western biomedical jargon. I mean, in the chiropractic field, we're getting away from the term subluxation, for example, and we're starting to talk about sensitization. And so there's a lot of knowledge translational work that I'm doing with the Ontario Chiropractic Association that's sort of adopting some of these principles and terminology in sort of their paradigms, and their communications. And I think, again, going back to an earlier point, I think as we all move forward, I think terminology, mechanism-based terminology, is critical, that we kind of standardize this. Our group, Myofascial, we've already published a paper
mhm.
several years back on standardization of the terms myofascial pain and so on. But I think even looking at secondary hyperalgesia, for example, which I've been really diving into recently, secondary hyperalgesia, allodynia, these are all being sort of mixed because, again, pain threat. No one's really at least they haven't acknowledged in these papers the difference between the nociceptive threshold and the subthreshold. And that makes a huge difference because allodynia is subthreshold, hyperalgesia is suprathreshold. But I don't think that we haven't really defined it clearly in the literature. So there's a lot of that out there right now, and there's heterogeneity in the literature. So moving forward, I would recommend to all of the listeners, be sensitive to terminology, and let's sort of move towards a mechanism-based paradigm.
John, if people are interested to follow more of your work, obviously I recommend them looking at some of your publications. Are you also involved in social media and keeping people up to date with what you're doing?
I'm actually not technically advanced. I'm not on social media.
That's okay.
No, neither was Jack until recently.
It's a good thing or bad thing, I'm not sure. But I am very happy to do these, again, nice, energetic, young, energetic individuals that are really looking to advance the field. I'm very happy to collaborate and do these talks. You guys have asked some really, really key questions, so you've done your homework for sure, and you seem very astute clinicians. So congrats on that. But I'm very happy to, again, anybody wants more of this, certainly let's do it again.
Yeah, great. Thank you again, John, for being with us today. I'm sure our listeners will get a lot from it, and I think it will really help to expand people's understanding of some of the connections through the neurogenic hypothesis.
Thank you very much. Thank you very much, and have a great day.
Yes,
evening.
indeed.
Have a good evening.
Yeah, indeed.
Take care. All the best.